Good morning, good afternoon, and good evening to all our friends and colleagues around the world. Today, we have a very special friend with us from a very special friend, Professor Ahmad Madarati, who is joining us today on the Podinar session. I would like to welcome you, sir, for this Podinar. Thank you so much.
Thanks a lot, dear friend, Dr. Prashant. It's a great pleasure and honor to be with you today.
Thank you so much. Well, as we all know that the time is changing and we are seeing that the world is changing as well. And we are now more on the virtual world. Definitely, we would like to see you somewhere with our global summit in future. And
Yeah, I hope
Professor,
so.
I would like to understand that what you know, like how you take it further, like how the dentistry is changing, especially the field of endodontics. We both are endodontics and we have been working to the core levels of the endo. So we would like to
Mhm.
know your opinion that how after this pandemic the things are changing from the hand instrumentation to the rotary and how the pandemics will going to affect the field of endodontics.
Yeah, true. Brother, that dentistry and endodontics in specific has been changed dramatically in the last, let's say, 5 or 10 years. And we have to admit that in the last 30 years, a lot of innovations like the ultrasonics, the rotary, the night eye rotary systems have changed a lot. New materials like the MTA, the MTA replica. So a lot of changes in the endodontics, which, and also our understanding of the tissue healing and the regeneration of tissue has a great impact on the protocols of treatments. Like uh, 10 years ago, or maybe 5 years ago, we never thought, or like a necrotic case can be regenerated. So you know that the trend. Now we have the trend like treating of failed cases. We treat only the failed root canals, and the others we keep them. So a lot of concepts and principles, and in addition to the innovations, have changed the way that we deal with endodontic cases.
So, what I believe, as we both are endodontists and we have been working very extensively to the core levels as we have discussed, especially for our group, the excellence in endodontics, which is again doing a very wonderful task all across the globe. And
Mhm.
so it's like we are here. Like, can you tell us about the group that we have been working at all together?
Yeah, actually, and this is another trend with the social media. The education process has changed dramatically, and we can see like a lot of dentists and colleagues, clinicians are relying on the internet sources, especially the social media. And frankly speaking, 5 years ago, it was like a great impact on me to think about the excellence in endodontics, because I used to communicate with the colleagues by WhatsApp, by Messenger, and then I came up with the idea: why not to create a platform that we can reflect our thoughts, we can like contribute to the dental community, spreading the knowledge, and that was the reason behind why we created excellence in endodontics. But to be honest, and you know that we needed to do some to do the thing in different way. It's not like excellence in endodontics. We need to reflect the excellence in the education, how we deliver the information, how we change the principles and concepts of dentist perception about endo. We, and you know that we the group is not only for showing off. We, you know,
Yeah.
that we don't accept any cases, any post, unless it is informative, unless it has a
Right.
message, it has clinical tips, it has clinical hints that helps our colleague over the world to improve their practice in endodontics.
Yes, indeed. I believe the same that we are being joined hands together and we are actually blessed with the people who have joined our group at the excellence to help us to grow together. And that's what we believe that learning and sharing, as I always say, is a continuous process. And we
Yes,
learn from each other, we share from each other because I think there is no end to learning. It's like
yes,
the day you stop learning, you are no more. I say we are all like educators. We try to educate as much as possible with our newer concepts, newer learnings. And we would like to thank all our moderators, all our the team members and especially Professor Ahmad for actually creating this, I will say, a scientific and a evidence-based and a clinically oriented platform for
Yeah.
all the dentists. Is not only pertaining to just a general dentist or an endodontist. It is actually open platform for everyone. So again,
For
on the
every
part and being a part of that same group, I would like to invite all our viewers who are with us on this webinar session to please come and join our group and help us to grow, and let's grow together. And that's the
yeah,
motive. I think we all have been working together. No doubt it's a virtual, but yes, learning is always the way it has to grow, whether it is virtual or it is in physical form. I believe the same. And
yeah.
I really salute Dr. Ahmad Madarati for actually doing this wonderful job and getting all of us together. And we are actually honored to have you with us on the Global Summit. So
Thanks a
before
lot.
Dr. Mehmet takes the entire show and rock the show, let me have his few of his credentials with you all.
Yeah.
Dr.
Um,
Ahmad Madarati is an associate professor and a consultant in microendodontics at the Taliba University, Saudi Arabia, following a postgraduate diploma in endodontics and operative dentistry in 2001, and a clinical master degree in endodontics in 2003 from Damascus University, Syria. Professor Ahmad Madarati attained his PhD in endodontics from the University of Manchester, United Kingdom, 2010. His experience in endodontics is recognized by the Royal College of Edinburgh, UK. His academic achievements on the state of technologies and microendodontics in both private and academic practices. Professor Madarati has been involved in undergraduate and a postgraduate education, including the establishment of the residency program in endodontics. Dr. Madarati was ranked as one of the top young researchers in the health and medical sciences and was the runner-up of 2011 Scopus Young Researcher Award in United Kingdom, which was delivered by Elsevier in association with US and UK Commission. Professor Ahmad has over 50 publications in the prestigious Dental Journal. In addition, he is an associate editor to one of the European Endodontic Journal, as an advisory board member of the Saudi Endodontic Journal. He's also an official reviewer for the several prestigious journals like Dental Materials and International Endodontic Journal. Professor Madarati has been remarkably lecturing internationally as a keynote speaker and won many awards as a best speaker for the best presentations. And that's what we're going to have it today. Professor
I
Madarati is
hope
the
so.
founder of the Excellence in Endodontic Groups and extensively supervising a continuous education hands-on courses worldwide. With the extensive clinical experience, a strong academic record, and achievement combined with distinguished research and publication achievements, Professor Madarati always seeks position that enables him to build upon these achievements and successfully progress his career. I'm actually honored to welcome you, sir, on this forum. And without wasting much of your time, and the topic of the today, that the protocols of cleaning and shaping, which is, I think, one of the basics in endodontics that we actually looking at with the basic to the advanced level. So I request Professor to please take over the session and enlighten us with your experience. Thank you.
Thanks a lot, my friend, for this nice introduction, and I hope that I can deliver informative lecture to all of our colleagues around the world. I will start directly in our webinar. I'm sure all of us, or majority of us, have come across this movie, What Women Want, and I like usually to start my webinar with this question, and actually most of us till now, maybe if not all, we have not been able to answer this important question. But as a dentist, I think all of us, we should and we must know what we want at the end of the day when we do root canal treatment. Like, for example, in this case, the patient attended the clinic with the chief complaint of pain on mastication, and the X-ray shows periapical lesion. What we want to do good root canal treatment, and after a few years, or maybe 10 years or 20 years, we want the patient to come back with functional and aesthetic tooth that is remaining forever. This is what we want. And if we want to talk in details, What we want all colleagues to like and love doing endo. We want to do endo comfortably. We want to do endo safely without any mishaps, any mistakes, any complications. And we want to do endo as fast as possible so we can treat more patients and we can make more money. And of course, we don't want our patients to suffer from post-operative pain in the long term or short term. And of course, we want to increase our success rate when we do endo. And as I mentioned earlier, we want to make more money and greater income. How to do that? I always stress on the basics. The first step of doing that, we need to rely on preoperative radiographs. So please take and read preoperative radiographs carefully. And talking about that, I stress, please, colleagues, do not rely on panoramics to do RCT. Why I'm saying that? Because unfortunately, till now, I can still see some colleagues, they're doing endo from A to Z just by relying on panoramic view. Like in this case, which was referred to me, the previous dentist dealt with the lateral incisor and just using the panoramic, and he relied on the panoramic. And instead of doing access cavity like this, he kept searching for the calcified canal and going and preparing, instead of access cavity in the coronal part, he extended his access cavity to the root. Why that happened? Simply because he didn't take preoperative and read that the canal is calcified. We need to know that a radiographic examination is just one piece of the puzzle when we want to know the endodontic disease and how we're going to deal with this disease. What kind of information we can get from preoperative radiographs? We can evaluate their restorability. We can explore the morphology and position of the bulb chamber, whether the bulb chamber is reduced and where are the canal orifices are located, how many canals. We can estimate the access depth, where we're going to start our access cavity. We can estimate the number and location of canals. For example, in this lower premolar, we can see the root canal in the coronal part is clear and it is divided into two canals. So we already have a complete idea about how many canals. Is that important? Yes, important. Because if you are going to assume that lower premolar is only one canal, you will end up with instruments fracture, because the two canals are usually very narrow. Since we are talking about preoperative radiographic examination, we need to remember that the preoperative radiographs, the periapical radiographs, are 2D images. So we need to see the third dimension, so we avoid any problems and any problems as a result of imagination. We need to know that everyone interprets the radiographs differently. If I tell you, Dr. Prashant, can you read these radiographs to me? You will give me, you most probably will give me different information from other colleagues. Also, we need to know that whenever we read a radiograph, our interpretation might change if we read the same radiograph after a few weeks. So we need to know these informations. We need always to have shifted radiographs to know the exact morphology. So always, please, always shift radiographs and take BA in two different projections. Why that? Simply because we will most probably miss one extra canal. Like in this study, which was published a long time ago, it showed that after examining about 800 mandibular incisor and premolars, this study concluded that there was a failure to identify 30% of twin canals from a single radiographic view. So if you don't take shifted radiographs, that means your success rate will be reduced 30%. What can a missed canal do? It can do a lot. This case was referred to me, even though it was performed by endodontic residents. We can see the radiographs. The obturation is very nice. It can reflect. It reflects the great efforts by the clinicians. But even though the patient still suffering pain after the treatment, simply why? Because of missing canal. And here we need to remember. And here we need to remember very important rules that canals are always centralized. What does it mean? It means like if you have one root and one canal, the canal is always in the center. Like in this case, we can see that it's definitely one canal. Why? Because the mesial and distal distances are the same. That means it is single canal. If we go back to the case, this case which was referred to me, simply we can see that the canal is not centered. That means there is another canal. By taking a shifted radiograph mesially or distally, and usually the shift is not more than 20 degrees. Please remember that it must be must be no more than 20 degrees. We can see here the first root, which has the canal that filled, and we have the other root which includes the missed canal. Just by taking the radiographs and using magnification and following the principles and the concepts of endodontics, we can achieve the results that we want. Another thing which you might see, might be surprised, what dental dam isolation to do with the cleaning and shaping? It relates strongly because first of all, nowadays we are suffering from the COVID-19, and the latest article published, it was in April, it talked about the dental practice and the importance of rubber dam isolation. So we want to protect ourselves from COVID-19, so we must do endo under rubber dam isolation, and I do recommend every colleague to use rubber dam isolation for every restorative procedures. Please protect yourself. This article talked about the rubber dam, and it stated that the use of rubber dam can significantly minimize the production of saliva and blood contamination, aerosol or spatter, particularly in cases when high-speed handpieces and dental ultrasonic devices are used. So whenever you're going to use high-speed or dental or ultrasonic devices, you must use rubber dam isolation. This article cited many articles which confirm that using rubber dam isolation can reduce the spread of infection. But what is important, more important regarding cleaning and shaping, is that using dental dam isolation can reduce the post-operative pain after doing endo. This study showed that the continued pain after RCT was less frequent in patients who received root canal treatment under rubber dam isolation. So definitely you want your patient to be comfortable during the RCT and after doing the RCT. So please place rubber dam. Another important reason why we have to use rubber dam while doing endo is this. We don't want our patient to inhale or ingest files, because this accident is fatal. It can end up with death of the patient, and we don't want this accident to happen, because once it happens, it might be it means that your career is over. So please, if you are not convinced with all other reasons about and the advantages of using rubber dam, this must be a strong reason for you to start using rubber dam while doing root canal treatments. And for me, I always suggest strongly that whenever you're going to do restorative procedures, it must be done under rubber dam isolation or dental dam isolation. While we're doing RCT, if you are not placing rubber dam, or if you are placing rubber dam but not getting tight seal, your patient will feel awful, strange, weird taste. The patient will tell you, doctor, I feel weird taste and my mouth is burning. Oh, it's my fault. Sorry. Why? Because I'm not placing rubber dam, or I'm placing rubber dam, but I'm not obtaining tight seal. What does it mean? It means like sometimes you may place the clamp and you place the rubber dam sheet, but you are not getting isolation. Like in this case. This case was performed by one of my students, and he wanted to show me what he did, but I noticed that he didn't obtain tight seal. So I told him, I took the photo and I told him, do you think that you are placing rubber dam? Do you think that you are obtaining tight seal? Once he saw the picture, he said, yes, that's not rubber dam isolation. What is rubber dam isolation? This is what we talk about when we say tight isolation. The environment, the operating field should be completely isolated from the patient's mouth. So we need to place a rubber dam sheet and the clamp and the liquid rubber dam. And this video can show what I'm talking about. In such case, we need to evaluate the restorability. So first step is we remove the caries. We might do that without rubber dam isolation. It's okay. So it's okay in some cases to start access cavity preparation or caries removal without placing rubber dam. But if you can do that, please place rubber dam and get the advantages of that. As you can see here, I'm removing the caries with the low speed. After that, I'm reducing this part of the tooth out of the occlusion, so I protect it while during the visits it doesn't fracture. After removing the caries, I consult with the prosthodontist. He confirmed that the teeth are restorable. So it's time to start our root canal treatment under rubber dam isolation. I rebuild the tooth to be able to place the clamp, placing the try in the clamp. After placing rubber dam, it is leaking, so I have to place liquid rubber dam, and here I'm using Orasil, just to make sure that there is no leakage and the patient will feel comfortable, that the irrigants will not go and burn the patient's mouth floor. And as I mentioned, there are 20 advantages of placing rubber dam. I included just 2. As we talked in the introduction, me and my friend Dr. Prashant, about the importance of social media, I usually receive many questions every day on WhatsApp and Messenger and Facebook. This was one question that I received from one colleague. It is in Arabic, but I wrote the translation in English. Doctor, while I'm cleaning the root canal, sorry, it's mistyped because I just wrote the translation today. While I'm cleaning the root canals of tooth with all the amalgam restoration, a small amalgam chip fell in the canal and blocked it. So what should I do? This brings us to talk about the importance of removing of all the restoration when we do root canal retreatment, or even treatment if there is amalgam restoration or composite restoration. So whenever you have old restoration, and here I'm not talking about crowns, I'm talking about coronal restorative materials, we must remove old restoration. Why? And here I would like to thank Dr. Saeed Saud because this periodical radiographs for him, and I took his permission to include it in the presentation. So why to remove old restorations? Simply, this will prevent canal blockage by restoration chips during access cavity preparation and during root canal cleaning and shapings, and this is what I was talking about. It will enable us removal of the recurrent caries if it is beneath the coronal restoration. It will enable us to evaluate whether the tooth is restorable or not. If the tooth is not restorable after removal of the caries and the old restoration, so there is no point of doing RCT and charging the patient with money. Also, another advantage of removing old restoration is that it prevents the post-operative coronal leakage. Why? Because if we remove some of the restoration and we leave others, the restorations are loosened by the vibration of the access drilling while we drill through the restoration but with high speed and low speed. So the restoration will be loose and there will be no tight contact and seal between the restoration, the remaining restoration, and the coronal structures. So remove all restorations before doing RCT. After I remove the old restoration and after I prepare the access cavity well, and before inserting any file, usually I irrigate for 2 minutes with full concentration of sodium hypochlorite. Why that? I got a lot of advantages. You can see here how the bulb tissue, the coronal bulb tissue, and even the bulb tissue in the coronal part of the canal are being dissolved. This will dissolve the soft tissues, as I mentioned. It will also facilitate the first insertion of files. You can see here on the right side, this is just after access cavity preparation and irrigation the bulb chamber for 2 minutes. You can see the canals clearly. That means I can get better visualizations. So these are the 3 main advantages of irrigating the bulb chamber with full concentration of sodium hypochlorite, and even I heat the sodium hypochlorite up to 180 degrees for 5 seconds. This will enhance the action of the sodium hypochlorite. We need to think differently. What do I mean by that? Whenever we have a case like this, the first thing comes to our mind that we want our files to get to the apical part, apical third of the root canals. This is like by default, our thinking there always. We need to change this mentality and we need to think coronally, because what makes the file goes easily to the apical part is the coronal part, not the apical part. What do I mean by that? These are sections of true teeth. So whenever we insert K5 number 10s to the canal, and here I'm talking about molars, I'm not talking about anterior teeth with wide canals, I'm talking about narrow canals in multi-rooted teeth. Whenever we try to insert K5 number 10, you will notice that it doesn't go more than the coronal or middle third. Even though the portal exit, it can accommodate the K5 number 10. I mean, if you try to insert the K5 number 10 from the apex towards the coronal part of the canal, it will go. So why it's not going, even if you keep trying, you will create ledge and you will create artificial canal and you will end up with perforation. Why that? Even we can see that the middle part and the coronal part of the canal is wide, simply because our problem might be like this narrow part of the canal, but the main obstacle is the coronal part, which is what we call the Dentine Triangle. This Dentine Triangle will prevent usually the K file from going to from reaching the apical third, and it might cause instrument fracture. We can see here this instrument fracture. Even the canal is wide in this part. Maybe it fractured because the canal is narrow here, but I will also assume that the dentine triangle caused a lot of stresses on the file and caused deflection while inserting the file. So my advice to you, to remove dentine triangles. Now, some colleagues might say that this is against the new trend of minimally invasive endodontics. They're talking about this. I will say, come on. What we usually do is just remove no more than 1/4 or 1/2 millimeter, no more than that, from the cervical area. I used to suggest using Gates-Glidden drills to remove dentine triangle, but nowadays I no longer recommend using them. Why? Simply, I came across this article, which in this article, in this study, it compared the Gates-Glidden drills with some rotary systems in creating micro cracks in radicular dentine. And we can see from the result that the Gates-Glidden drills cause significantly the highest percentage of dentine microcracks compared with other rotary systems. So that one reason for me to stop using Gates-Glidden for removal of dentine triangle. What I use, usually I use the ultrasonic tips that is designed especially for working inside the bulb chamber, because we know that there are special ultrasonic tips to be used inside the canals, and there are other ultrasonic tips that are designed specially to be used within the bulb chamber only. We can see here, this is definitely not against the minimal invasive endodontics concept, or maybe 1/2 millimeter of the dentine triangle. And notice here that under magnification, I'm not touching the forcation area of the canals. So this is why what is good about using ultrasonic rather than using Gates-Glidden or other means like rotary files or even low-speed burrs. So just using the ultrasonic tips under magnification, you will be able to remove the dentine triangle. And here we can see this is the bulb chamber before removing dentine triangle by ultrasonics under magnification, and this is after. And you can imagine that if you're going to insert the file, which is easier for you and for the file, to insert the file in this canal, in this bulb chamber, or in this canal after removing the dentine triangle. So this is a triangle, as I mentioned, which prevents the K file from reaching the apical third of the root canals, even the canal is patent. Once we remove the dentine triangle, as I mentioned, by ultrasonic tips, we can insert the files and the rotary files and enable them to reach the apical third and complete cleaning and shaping and getting and doing obturation and get the result that we want. Implement magnification. What to do with magnification with cleaning and shaping? And before that, please don't misunderstand me. Some colleagues, unfortunately, they understand that when I say magnification, I mean microscopes. No. What I mean by magnification, you are able to see simply. So whether using microscope or whether loops, it's up to you. As long as you can see what you do, that's fine. Use whatever you want. Do we need that? Because they are denying the impact and the great advantages and the essential, the essence of using magnification in endodontics. Here are some evidence, some articles. As we remember that in 1917, Walter Hess was the first to clearly show the presence of MB2 canals and maxillary molars. So it was long time. It's not a new thing. But the new thing that we need to use magnification and microscopes or loops to be able to see them. This article, this study, which was published in the Australian Endodontic Journal in 2002, it shows the importance of using high magnification in locating the orifices of MB2. In this study, the MB2 were inspected first by first examiner using 2 steps of magnification by loops, and the teeth were examined by another investigator using operating dental microscope under 10 times magnification. And finally, the teeth were sectioned to confirm whether the MB2 was there or not. What were the results? The histological inspection revealed that in 63% the MB2 canals were there. The examiner who used the loops was able to identify and locate only 41% of these MB2s. On the other side, the clinician who used microscope magnification was able to reveal and locate 94%, almost 94% of these MB2 canals. Another study which aimed to evaluate the influence of dental operating microscope for the detection of the MB2 canal orifices in 108 randomly maxillary molars, almost the same methodology, using microscope or mirrors and using loops and sectioning the teeth to confirm the presence of MB2. What were the results? The results showed that the orifice was found in almost 91% of the teeth, so 91%. Some colleagues keep asking me, doctor, what is the percentage of MB2? My answer simply, you have to consider that it is there all time. Consider it is there unless the opposite is proved. In 90% of this study of teeth in this study, the MB2 was there. MB2 canals orifices were detecting only in 53% or 54% using the mirror. So if you are a kind of clinician that not using any tool of magnification and you are relying on your eyesight, that means your success rate will be reduced 46%. Another 34% orifices were located by dental operating microscope. Only even with using microscope, we might miss up to 3% of MB2. So what was the conclusion of this study? The first conclusion was that MB2 is present in 91% of the cases. The adjunctive use of dental operating microscope increased the ability to locate the MB2 canal orifices. Again, some colleagues might say, oh, we are able to locate MB2 even without using any magnification. So my question to them, were you able to negotiate all the MB2s that you located? I'm sure you were not. Because this study shows the importance of magnification, not only for locating MB2, but also to negotiate them. The study was published in Journal of Endodontics. Initial location and negotiation of MB2 were attempted without any magnification, as usual. This is the protocol. Then using dental microscope, and finally sectioning the teeth to confirm the presence of the MB2. What were the results? Without magnification, the MB2 was located in 93%, but only 69% were negotiated. So again, here, this study confirms that we might able to locate the MB2, but without magnification, we might not be able to negotiate them. With the dental operating microscope, the identification and negotiation was increased to 80%. The root sections confirmed the absence of MB2 in all 9. So, in conclusion, MB2 can be negotiated in 80% of maxillary molars, although an orifice is apparent in 96% of the teeth. And the ability to negotiate MB2 is facilitated by dental operating microscope. So, in summary and in conclusion, dental operating microscope doesn't only help you in locating the MB2, but it also helps you to negotiate them. Like in this case, definitely magnification was a crucial factor that enabled me to locate and negotiate the MB2. We can see here using or relying on the what we call the color change or the pulp chamber floor mapping. This is the palatal canal. This is a distobuccal canal, and this is a mesiobuccal canal. And we all know that the MB2 is usually located between the MB1 and the palatal canal. It might be a little bit towards the mesial part. So I have to, and by relying on the bulb chamber floor map, I know that usually the canals orifices are dark or the darkest. So I just follow this line and I can see either here or I can see that there is something there. I take number K5 number 6, okay, and start getting there, and I could feel a catch point. So that means it is canal. Keep going with K5 number 6, and then that's after, just after K5 number 6, we can see the difference between without negotiating and with initial negotiation using K5 number 6, then K5 number 8. You can see that using more K5s, it enables us to negotiate the canal more. And once I'm reaching or I'm there and I'm going deeper in the coronal and middle third, I can rely on the rotary to flare that part. We can see here. Once I reach with the K5 to the apical third, that means the canal is finished for me. We can see the journey from dark spot, tiny spot to well-cleaned canal. And this video can show you all steps. Under magnification, as I mentioned, always follow the dark spot. First insertion of carbon steel file. In such cases, definitely we need to be patient. We need time. Give enough time to the small files. Give enough time to the first file that will reach the apical area of the root canal, because it is the most important file in cleaning and shaping. Copious and continuous irrigation is also crucial, because the debris should not block the canal. Keep irrigating, and when I say irrigating, irrigate, recapitulate with K5 number 10 or 8, then irrigate. By doing this, I'm sure that I'm removing all the debris from the root canals, which might prevent or which might block the canal if I don't do proper irrigation. We can see that from tiny dark spot to well-cleaned canal orifice. All what I needed is magnification, ultrasonic at the beginning, of course, to explore the canal, and time. That's all what I need in dealing with such cases. Now, do what are the advantages of magnification? Actually, there are more than 12 advantages for using magnification in endo. One of them that it helps us in some cases to do proper cleaning and shaping. We know that a root canal system is not as simple as we think. It's a complex root canal anatomy, that it has lateral and accessory canals. It has canal walls irregularities. It has fins and cul-de-sacs. It has isthmuses, dentinal tubules, and the apical curvature. And we need to clean all of these areas if we can do that. In the last 10 years, most companies or some companies introduced the 3D rotary instruments, which enhanced to some extent cleaning and shaping of the root canal system. But for me, in some cases, I use thin ultrasonic tip to clean properly isthmuses that connect two canals together. As long as I can see, and of course, to be able to see what I do, I have to do that under magnification. As you can see here, under magnification, using small ultrasonic tips, I clean with sodium hypochlorite, I clean the isthmuses that connect the two canals together. 20 years ago, we never thought to do that because we thought that it is impossible. But with magnification and with the introduction of new ultrasonic tips that are very small, nowadays we can maximize cleaning and shaping. Another example. Lateral canals or calcified defects, these areas cannot be cleaned properly by rotary files. Here you can see this, what I mentioned earlier, that I'm cleaning the isthmus between the two canals, and you can see the debris and the infected dentine irrigation. Look how much debris come out from the canal. So we need to keep irrigating, and I always tell my students, between irrigation and irrigation, do irrigation. And when we say irrigation, it means irrigate, recapitulate with K5 number 10, and then irrigate. That maximize removal of debris from the root canals. You can see here, I'm maximizing the cleaning. Supplementary effect of the intracanal medication using calcium hydroxide. This enhance the eliminating of bacteria from the root canal systems. Then I remove, I insert cotton pellet to enable easier removal of TF in the next session. And when I talk about the temporary filling, it should be at least a 3 millimeter thickness to provide good coronal seal. This case was referred to me, and we saw the video earlier, for dealing with these two premolars. One of them was with previously initiated root canal treatment. As I mentioned earlier in this webinar, we need to do proper pre-operative radiographic examination. And we can see that from the radiographs, we can get a lot of information. Case difficulties, restorability here, it's a big aspect that need to be addressed properly, and that after complete removal of the caries. Missed canals, as we can see, calcified canals, root canal system complexity. Here the canal, and then divided into two canals. One of them is clear, the other is not clear. That means it is very narrow. We can see here tiny canal that the previous dentist couldn't negotiate it, and also he couldn't he or she couldn't negotiate the other canal. Here we can see, but we can see shadow of the canal. And my rule for all colleagues, like whenever you see two canals in the pre-operative radiograph, then expect a third canal. Always predict more than what you see. So if we look carefully to this pre-operative, I can see a shadow there. So I'm predicting that it is 3 canals. And why that? Why I'm stressing on that? Simply, this study shows that the failure rate of root canal therapy in all teeth, it is significantly higher in lower premolar. So when they investigated the failure of root canal treatments, they found that lower premolar had the highest failure rate. Why? I think because one possible reason is the complexity of the root canal system. We can see here the importance of magnification. I was able to locate 2 canals and look for the third using a carbon steel file. I was able to get the catch point, K file, and then it was long journey. All what I needed: magnification, time, and being patient, and using the right instruments, and don't rush. So don't rush in dealing with such cases. Why? Because the most important file in root canal treatment is the first file that will reach the apical third, which is usually K file number 10 or maybe K file number 8. Dealing with the other canal, the same. Just give yourself enough time. And of course, in dealing with such cases, you need a lot of K file number 10 and 8. Usually, when I insert such files once or twice, I discard them. I don't keep working with them. Look here, the importance of magnification, the 3 canals. Following the same protocol, I was able to deal with the other premolar and negotiate 2 canals. And here is a video that summarizes all what I did. Lingual canal and distobuccal canal. Just rely on the color changes. Give yourself enough time when dealing, when using small files. Once you negotiate them, you can use rotary, working length. For me, I like to use new generation files. I stopped using old generation rotary files. You can see the importance of magnification. Without magnification, no way to finish such case. Especially, it was very difficult to me doing the obturation. The coronal part of the canal didn't allow me to insert 3 master Cotabercha cone at once. Dealing with the other premolar, following the same protocol, the same rotary system, and the proper irrigation protocol. Just follow the basic principles and concepts and you get the results that you want. What are the lessons that we can learn from this case? First of all, read the preoperative radiographs carefully and evaluate restorability, as I mentioned. Never go beyond your limitations. And for me, everyone can improve their and overcome their limitations by knowledge and good training, and I will talk about this later on. Magnification is essential for finding and negotiating hidden canals. Spend enough time using scouting files, and remember that the first file, the most important file, is the first file that will reach the apical third of the canal. Each case has its own conditions, which may necessitate different approaches. Scouting and glide path preparation, as I mentioned, I focused a lot on that because I consider this as one of the most important steps in cleaning and shaping. And when we talk about scouting and glide path preparation, usually we talk about K5 number 10, but sometimes in some cases we might focus on file number 8. And of course, the introduction of glide path rotary files has improved the process and saved some time. But don't rush in dealing whenever scouting and glide path preparation is crucial. This paper reflects the importance, and it shows the importance of glide path preparation in endodontics, a consideration of instruments and literature. Simply, it focuses and it shows that we must prepare glide path. Why I'm saying that and why I'm stressing that? Because unfortunately, there is a trend, a new trend that is followed by some colleagues that they can prepare the canal from A to Z using single file without the need for glide path. It's not about just a space that we enlarge. It's about cleaning and shaping a complex root canal system without damaging the file, without damaging the dentine. And by damaging dentine here, I'm talking about creating micro cracks. So just follow the principles. Here in such case, I wouldn't be able to complete it if I didn't give enough time to K5 number 10. In calcified canals, do not be economic. These files just for managing one canal. So in some cases, we might need up to 20 or 30 K5 number 8 and 10 to finish the case. Sorry, as I mentioned earlier, each case has its own condition. So we cannot be definite saying like, okay, this case we will need maybe 5 K5 number 10, or we might need 10. No, it's according to each case. But the important thing that we need to remember, each canal might need more than 1 file, 2 files, 5 files. And for me, just when I send the file once or twice maximum, I discard it. In summary, I'm going to summarize all the points. Think differently and change your mentality and be logical. Take and read preoperative radiographs carefully. Always take shifted radiographs so you can see the hidden canals. Apply dental dam isolation, especially now in the era of COVID-19. And since we are talking about dental dam isolation, you need to remember that placing clamp and rubber dam doesn't mean tight isolation, so you have to use liquid rubber dam. A retreatment, remember that you must remove all the restorations. Irrigate access cavity before inserting any file. Remove Dentine Triangle. This is one of the top secret in Indo. Implement magnification. Rely on color changes, and scout well and prepare glide path. The learning curve. After graduation, don't stop learning, please. And remember that the knowledge, what you know during the 5 years or 6 years of studying at the College of Dentistry, is just the start. You need to keep updating yourself. And then whenever there is a need and you want to apply new techniques, you need to have hands-on courses. And after that, you need to practice what you learned in the hands-on courses. You need to practice that on extracted teeth before you start practicing the new techniques on patients. Once you start on patients, start with the easy cases, then shift or move on to moderate cases, and finally deal with difficult cases. This is a learning curve that I usually teach in my courses. And this is what we are trying to stress in our group, Excellence in Endodontics, and thanks to Dr. Prashant that allows me to talk about it in the introduction, and we talked about this, but we are going to talk again, and I will take the opportunity here to thank all my team, the silver members, the gold members, the executive board members, for the great efforts they did during this 16 months after 1.5 years now of this group established. Proudly, we are the fastest growing group in Indo. Now we are approaching 47K members. Why that? Because simply we don't accept any case unless it is informative. Why this group is attracting a lot of clinicians around the world? Because of the policy that we are adopting, and we keep conducting and making webinars, online conferences. This was the first online conferences, which was in March, and we just finished last month the second international online conference, and in 3 days we will have another excellent conference, in which I invite all of you to attend the lectures. This is going to be with the collaboration with the Jordanian Endodontic Society. Excellent speakers will be there, so stay tuned. In my courses, I usually rely on fully equipped courses, including microscopes, including ultrasonics, and we always fully booked in these courses. So far, I met excellent groups over in the Middle East, in Turkey, in Saudi Arabia, in Egypt, in Jordan, Saudi Arabia, and different cities in Saudi Arabia. Great colleagues, great groups that were keen to improve their practice in endodontics. And this was in Egypt. Again, this was in Nigeria last year. Yes, another course, excellent course with excellent group of endodontists and dental practitioners in Jordan, Saudi Arabia. As you see, fully equipped courses, great attendees, happy with what they did, removal of fracture instruments. Some of them never thought that they will be able to remove fracture instruments in their life, but they were able to do that. Big regards to all of you guys. I miss you all. Dr. Muhammad Saeed, Dr. Muhammad, all of you guys, I miss you all. This guy, special regards to this guy. He was able to remove 5 fracture instruments in one course. So I consider it as a new course world record. The mission is going on. I had great pleasure to meet these 2 guys, Arnold Castillo, in the Pan-Arab meeting, which was held in Marrakesh, in Morocco, last January. This photo can tell the whole story. The mission is going on, and that's why we will rely very soon in the on the new generation of excellent clinicians. These guys from Syria, stay tuned. They will present a lot of excellent stuff very soon, so stay tuned. You are more welcome to attend my next webinar, which will be in a few days, as I mentioned, in the second Jordanian Endodontic Symposium. And I will talk about the complications of fracture instruments management, science versus clinical practice. And I also invite you to attend this important event, which will be in November. It's my honor and pleasure to share the stage with great colleagues from all the world, including my friend, special friend, Dr. Ashraf Rifai. Big hello, Dr. Ashraf, to you, and big hello to everyone. And thanks, my dear Dr. Prashant, for this kind invitation. This is my contact details, and I am pleased that if you follow my personal page, which is Prof. A. Madarati for Excellence in Endodontics, to see and attend all the important stuff, scientific stuff in Endo. Thanks, Dr. Prashant, and thanks, colleague, for attending this webinar. I hope that I was lucky to give you informative lecture.
Well, thank you so much, Professor Ahmad Baditi, for this enlightening session on the cleaning and shaping tips in endodontics. And I think all the colleagues and viewers around the world would have benefited from your vast experience. And it's always a pleasure listening to you with so much of in-depth knowledge, and there is so much of learning which is always there. So can I take some questions? Yeah. Can I take some questions? So there is a question like, which magnification you recommend for locating the MB2 if you have to do it through the microscope and or with the loops?
As I mentioned, it's we cannot say like I have to use microscope or I have to use loops. It's up to each clinician, because each clinician has his or her own ability. Some MB2s we might be able to locate them using the loops. Some MB2s we have to use microscope, and even some MB2 we don't need magnification to locate them. As I mentioned, and I showed some articles that locating MB2 might be by naked eye or might be by loops, but to get the best result, I recommend using microscope. First step or second step of magnification will be okay to manage them.
Okay. There's another question. What's your opinion about the negative pressure irrigation?
Definitely yes, but can all of us afford to do that technique? That's the question. So if not, following a correct protocol of irrigation, which means using more than one irrigant, is very important in getting the results that we want. And of course, when I'm talking about irrigation, I have to remind all colleagues about the importance of agitation of the air using ultrasonics.
There is another question which is actually complementing the same question. Like, what are the protocols of irrigation in endodontics you recommend? That's what we should use. It's a very common question which I've come across.
For me, I'm not going to say I recommend. I'm going to say that this is what I do, because Dr. Prashant, each his own. So what I usually do, I use sodium hypochlorite with activation for 1 minute. I used to do that for 2 minutes, but later on I realized that 1 minute is more than enough. Then saline, then edita with agitation for 1 minute, then saline, and then I might finish with sodium hypochlorite or might just finish with saline.
Okay. There's another question which says that when evaluating the X-ray to understand the anatomy of the canals, you explain to the audience what is fast break. That is a term, fast break. It is very useful in determining like what exactly it is. That's the question.
Yeah, for me, usually it means one of two possibilities. Either the canal is divided into two canals, or the canal at that point is start to be curved, severely curved in the bacolingual direction. These are the two only possibilities.
Okay. What is your opinion about role of continuous chelation theory in endodontics now in irrigation? Like,
can you say that again?
The role of continuous chelation theory that is being practiced. So, what is your take on in endodontic irrigation?
Education?
No, continuous chelation theory.
Continuous
chelation theory.
It's about the edita.
Yeah.
Can you clarify it, please?
Okay. So it's asking like, so nowadays we are using a lot of continuous chillation theory during the irrigation. Lot of EDT is like a continuous chillation you keep doing. So that's
Yeah,
the,
yeah,
yeah.
yeah. I got it. But what is the exact question? What, as I mentioned, my protocol uh, usually, and I have to stress that again. Uh, some colleagues, they care more about the final protocol and they forget about the irrigation during the cleaning and shaping, which for me is more important than the final protocol. What you do during the cleaning and shaping with irrigation is more important. So during cleaning and shaping, my role is very simple. Before you insert any file or after you insert any file, do irrigation. And when you do irrigation, just irrigate, recapitulate with K file number 10, and then irrigate. Why that? By recapitulation, when we irrigate first, we might be able to remove out some debris, but still some debris that are attached to the canal walls. So by inserting the K file number 10 and recapitulating, that means we are releasing these debris. Then we irrigate so we are able to remove more debris from the root canal. And that one main reason to reduce the postoperative pain, to reduce the possibility of canal blockage, especially in difficult canals.
There is another question like during master cone X-ray.
Yeah.
During master cone X-ray, sometimes we see that the master cone gets buckles or tints. What's the reason and how to avoid it?
It gets what? Sorry?
It gets buckles up like it's at the tip. It doesn't go at the working length, right? So there is a buckling at the tip of the master cone. So there is a question like how we can take care of it and how we can avoid it.
One reason, first of all, let's like we need to make sure that the master cone is getting to the full working length that we are working. If not, the first possibility for me that master cone, the size of master cone is not correct, and you know that if we have 10 master cones or 10 Cotebercha cones, we might find one or two are not correct in the size. So that is the first possibility. The other possibility is that there might be some debris, okay, a lot of debris that preventing the master cone to go to the full working length. So we need to make sure that we irrigate again and make sure that the master file is going to the full working length, and then bring the master cone Cotebercha again to the full working length. Right. I hope that I answered that question as far as I understand.
Yeah. You said that ultrasonics are to be used for the removal of the dentinal triangles, which is there. So what is the recommended speed that you actually recommended speed to use it? And should it be used in dry or wet conditions?
Okay, it's a very good question, and I will thanks to the colleague who asked this question. First, I would say instead of using speed, we call it power settings. Okay.
Yes.
So for me, it's not only power setting; it's also the time, how much you keep activating the ultrasonics. The higher power setting that we use, the shorter time that we activate, and vice versa. So for me, I don't keep activating more than 30 seconds or 1 minute maximum. Okay. If you can do that with irrigation or with coolant, that's fine. But as I mentioned, we need to see what we do. And that's why most of the time I prefer to do it without coolant, but for short time, using, let's say, the 2/3 of the power settings. If we have, for example, the scale of the power setting, of the ultrasonic unit up to 20, usually I use between 10 and 15 in that range.
Right. And let's take the last two questions. How to manage the S-shaped canals, and should we use rotaries in the severely curved canals?
That question needs 1 or maybe 2 hours of presentation. But simply, my suggestion is S-shape should be divided into 3 parts and deal with each part as if it is a canal. The coronal part, the first curvature, and the second curvature. That's it.
And the last question what we'll take is like, what is the motion of the first file in negotiation of the calcified canal? That's what is being asked. The motion
Is
of
it
the first file, like 6 or 8 number file.
a hand file or
Yes, hand file, hand file.
for me, watch winding. Watch winding.
Watch winding.
Yeah, clockwise, counterclockwise.
Right. Well, I think okay. One question which has just popped in: the role of intracanal heating of sodium hypochlorite.
The
role of intracanal heating or warming of the sodium hypochlorite.
It's very simple. The irrigant has chemical action, okay, whether in dissolving the pulp tissue or the active antibacterial effects. And any chemical action, once we increase the heat, the action will increase. Simple as that. And another role is the mechanical role. When they activate, we create like kind of vibration and current that push the irrigant to the irregular areas of the root canal system.
Well, that's the questions we have, and I think we have much more questions, but I think people will get connected with you on their email address. And
will come to send me the question on my personal page or an Excellence in Endodontics group.
Right. Well, thank you so much, Professor Ahmad Madarati, and as a chairman of the International Cooperation Committee of the Global Summit, I actually give you regards, and I would like to thank you once again to giving your precious time to all of us and to all the colleagues around the world. And thanks to the Group Excellence in Endodontics that we have come together and we are able to share another experience with all our colleagues and friends. And we are honored and humbled for your gracious presence for our webinar. Thank you so much, Professor.
Once again, thank you, my dear friend, Dr. Prashant. Thanks, Global Summit. Thanks, all colleagues who attended this webinar. And we hope that we meet again, inshallah.
Sure. Thank you. Bye-bye.
Bye-bye.
Thank you. Thank you.